Hello, friends. I'll be talking on this topic, which I think is challenging. Not many intensivists possibly would have delivered on this topic. So, this talk I had to deliberate in Madurai for one of their conference. So, I thank the Madurai guys for having me to talk on this. It's not an easy topic to talk on, and I'm sure not many intensivists would possibly dwell on this particular topic. So the topic is fever with rash. How do we approach? PBLD is patient-based learning and discussion. So I had to take them through the cases. So pondered about as to how to go around with this topic. So the way I would go about is we look into classification. So mainly focusing on dermatological manifestations in critical care. Basically, anyone who comes to ICU who are sick and who have skin manifestations. The way we look about classification. So we look into differential diagnosis, and then we look into what is the general sort of an ICU cases that come with skin manifestations and what will be their clinical profile. We'll only look into common ones because if we look into literature, there are a lot of cold cases, not necessarily which are ICU related. So I have only picked up the ones which are more ICU relevant sort of a situation and their clinical profile. And this is important. We look into the published studies on this. So honestly, there's not many studies. Most of the studies are limited to retrospective study, case series, prospective study, and case reports. There's no big trials or anything of that sort. So not many are there, but we look into what are all the published studies in this area and approach to a patient with fever and rash. So this will be interesting. So I'll be talking on around five patient-based learning and discussions, and I'll be mainly taking you through our own publications that we did in our ICU on the skin manifestations. So that will be more pertinent to this whole topic. Take-home message. So, and as I said, the rash with fever poses significant diagnostic challenges. So when you have a patient coming to ICU with fever and rash, the diagnostic challenge is twofold, and one needs to be clear as to how we delineate the causes. So when we try to approach any rash with fever, there will be many causes that will come to the mind. So one needs to look into these two broad categories, whether it's a life-threatening infections which is causing the rash, or it is a skin disorder which is mimicking serious infection. So for that, the way we approach is whether the skin rash was present prior to admission to ICU or whether the rash has developed within ICU. Because if a rash is developed within ICU, possibly you'll have a lot more cues to recognize as to what may be the cause. If it is prior to admission, then history becomes very important to ascertain what may be the possible cause. So I just put pictorially. So the commonest cause are infectious causes, and Staphylococcus aureus is a very common cause of skin manifestations with infection. And meningococcal sepsis or meningococcemia also is very typical and characteristically described as fever with rash coming to ICU who becomes sick. So staph infections, meningococcus, and I'm sure every listener here would be alluding to this fact that dengue comes to ICU with skin rash and leptospira. So any of these tropical diseases. So these are infective. So it can be bacterial, viral, and tropical. So in tropical, leptospira and the rickettsia comes, dengue, and in bacteria, it's staph and meningococcal. In non-infective, it will be predominantly autoimmune causes, and SLE is one of the common causes. And the third important dimension is the drug rash. So history becomes terribly important to ascertain if they have taken any new drugs, if they have taken any antibiotics off the shelf, so which can lead to drug rash. And toxic shock syndrome is a severely sick patient with skin rashes due to any of the infective causes. So these are some of the broad categories. Post admission to ICU, after they have been admitted to ICU and they have not had a rash and then they develop rash within ICU, I'm sure many of you would agree the common causes would be the drug rashes. So one has to review all the drugs that you may be giving, any new drug that is added, or someone with a background SLE and who have a flare also is a common cause. And staphylococcus still remains common even within ICU. If they develop a nosocomial infection with staph aureus, that can also lead to skin rash. So when you look at literature, the DM is dermatological manifestations. So I'll be calling as DM as we go along. So the dermatological manifestation in ICU is around 10.4% as published in this particular study from Spain. And Indian study, this was done in Vellore, CMC Vellore, where they put the dermatological manifestation as very high, 42.2%. But possibly 42 seems to be an overestimate because we'll come to the studies as we go along. But maybe 10 to 15% may be reasonable because most of the Western studies put that number around 10 to 15% as the dermatological manifestations in ICU. So when you look into literature, there are a lot of classifications and a lot of causes. But as I showed you in the previous slide, look at it as infective. In infective, look at bacterial and viral, drug rash, and autoimmune. I think those remain pretty much the broad causes. But the easiest way for all our ICU trainees, I say any cause, you can put it under this vindicate because pretty much any of these can be the broad sort of a cause for any skin rash. So it can be vascular. So if someone has a DVT or arterial thrombosis, they can have a skin rash. Infectious, we went through. It can be a feature of neoplasm as a paraneoplastic feature. Degenerative, very unlikely. Iatrogenic, drug induced. Congenital, very rarely. Autoimmune, we spoke. Trauma, endocrine. So this is something as a norm you can mention for any sort of a cause. You need to put it into a broad category. So now we look, I think that is more of general. So we look into classification based on type of skin rash. So this is more acceptable sort of an approach to any skin rash because any skin rash, you need to ascertain whether it's maculopapular, whether it's hemorrhagic, or whether it's vesicular. And all the standard conventional literature talks about approaching the skin rash based on the type of skin rash. So this is hemorrhagic rash. So this is, I'm sure most of the listeners, if you see dengue patient, at least during my rounds when I do dengue, I first look into the legs because legs are the place where you see a lot of these purpuric patches or hemorrhagic rashes. And the most commonest cause is dengue. And even Staphylococcus aureus is known to cause this hemorrhagic rash and meningococcal. So all these infective causes typically causes this purpuric rash or hemorrhagic rash. And rickettsia also can cause this, although typically what we look in rickettsia is for the eschar. Leptospira also causes this hemorrhagic rash and ITP is the non-infective causes. So based on hemorrhagic purpuric rash, so these are the causes. And these causes, if you see, are similar to the previous slide, where I said viral, bacterial, and in autoimmune, it can be ITP. So this is a rash where you have maculopapular sort of a rash. So, and the causes for maculopapular is all these causes again. So there is a lot of overlap. Although we may define rashes into maculopapular, purpuric, or vesicular are little different causes. But if you look at the causes, they pretty much remain similar. Even for maculopapular, the causes are the same. It can be dengue, it can be staphylococcus, meningococcus, rickettsia. Along with this, some of them are brucella and HIV. So this is something unique. So where if you see a vesicular, so this is typical vesicular. I'm sure it is very intuitive that it is due to herpes simplex varicella is the typical cause for this sort of a rash, vesicular. And this is a typical eschar, which we call it as ulcerative sort of a rash, and or you would call it in a simple term as eschar. And this is typically seen in scrub typhus. I'm sure most of the listener, when you contemplate on scrub typhus, you would look for this eschar in the skin folds in axilla or groins, but it can be present anywhere. So this is typically in scrub typhus. The other causes for such eschar is trypanosomiasis or leishmania. So although we don't see this very commonly in our country, so but in ICU we would typically see scrub typhus, and that is how the scrub typhus looks. So we look into just the clinical profile of fever and rash in different of these conditions. We just categorize into these four major categories. What is the type of rash that happens in different infections? And what is the timeline from the onset of fever to the development of rash? And then which are the conditions where there is leukocytosis, thrombocytopenia, and only the salient clinical feature that you may see in this rash. So we'll look into one by one. So this is meningococcal infection. The rash is typically described as central, which is it can be present on the trunk or it can be present in the periphery also. And in meningococcemia, the rash can happen or occur almost instantaneously with fever. The fever starts with the rash, so it's almost 1 to 2 hours after the onset of fever, a rash comes. There will be leukocytosis, thrombocytopenia may be present, and typically it happens in early spring, and they have a prodrome of upper respiratory tract infections, headache, And meningococcal infections, the patients can become very sick with hypotension and ensuing sequelae of that. So in rickettsia, which also is commonly seen in ICU, the rash is predominantly central. As I said, you would look for eschar at the skin folds in axilla, on the trunk, or in the groin. So it is considered as central. It is not seen in peripheral. The rash develops typically 3 to 6 days after the onset of fever, and we see in rickettsia the count can be normal, or sometimes there can be little lower total count. But invariably, we see platelets will be little lower, or they can have severe thrombocytopenia. And as I said, predominantly you'll see the rash in the skin folds in the axilla thorax. And the typical clinical presentation when they come to ICUs, they would come with multi-organ dysfunction. They could have secondary HLS, they can have liver dysfunction, they can have AKI, they can have encephalopathy, so on and so forth. So that is the typical situation we see rickets here. So typhoid also we see in ICU. Here the rash is central. It is not present in the extremities. So it occurs much later, 5 to 7 days after the onset of fever. And I'm sure most listeners would know in typhoid there will be leukopenia. White cell count will be low. Platelets can be normal. The typical clinical profile is they have step ladder fever. So they have a fever which keeps increasing every day. And relative bradycardia is very common in typhoid, which is another salient feature. And many typhoid sick patients who come to ICU, they could come with possibly because we've had instances where typically they come with a viscous perforation or GI symptoms, and encephalopathy also is very common in typhoid. So in Staphylococcus, the rash can have mainly occur in the limbs, peripheral, and it is also present on the palms and soles. So which is something which possibly will delineate from other sort of infections we spoke. The rash is predominantly present in the extremities, palms and soles, 3 to 5 days after the onset of fever. And Staphylococcus, I'm sure most of you would have seen in ICU, they will present with leukocytosis. Platelets will be initially normal, and when they get more sicker, they can have thrombocytopenia. And in ICU, Staphylococcus, they can present with multi-organ sepsis and septic shock. So this is sort of a clinical profile of different infections. And this is the typhoid maculopapular rash that is typically seen. And as I said, typhoid can come with, generally when they come to ICU, they come with encephalopathy or they come with viscous perforation, they come with shock, mainly as you see ileal and colonic perforation. We have seen it coming with this, and they can have liver dysfunction, and pericarditis, pneumonitis also is something that is present. So these are some of the symptomology of typhoid. So basically what we are trying to say is all the ICU presentations you saw, meningococci, rickettsia, typhoid, staphylococcus, the key hallmark is skin rash is present along with systemic manifestation. So you need to keep in mind in ICU, any skin manifestations, you need to do a good systemic sort of an examination and ascertain the definitive systemic cause, and treating that would eventually help in sorting out your rash. So this is what is the high point of all these infections. Then we look into dengue. I'm sure all of you are experts in dengue. So the rash is seen in central part, and it can be present in palms and soles, and it can be present in extremities. And the typical rash happens 3 to 4 days after the infection. And dengue, all of you know, they'll have leukopenia, thrombocytopenia. It occurs during the seasonal change. Liver enzymes can be high, hematocrit can be high, multi-organ dysfunction is not uncommon in dengue. Sure, many of you know, we won't dwell into all the other clinical, but this is how in dengue is seen. SLE, when it happens as a flare, the rash is usually present in central or in peripheral, and it occurs with flare. Whenever there is an exacerbation, that's when the skin rash happens. Leukocytes can be normal and platelets also can be normal. In SLE, one has to look at other system involvement, and we look at SOAP brain MD. I'm sure most of the listeners would know this is a mnemonic for remembering all the symptomology, systemic symptomology of SLE. So the typical rash in SLE is malar rash. I'm sure many of you would have learned this from MBBS. So you have a butterfly sort of a rash, and then they can have a discoid rash. So discoid rash looks something like this. So Sobrain MD, it's a very easy sort of a mnemonic to remember all the other features to look for SLE, serositis, oral ulcers, arthritis, photosensitivity, blood dysplasias, renal, ANA, immunologic, neurologic, and MND stands for malar and discoid rash, which we saw. So we'll move. So we finished all the bacterial causes. We looked at viral dengue. We looked at SLE. What about the drug rash? So the rash can be present central and it can even be present on palms and soles. This is important for drug rash. It takes around days to weeks before the rash manifests after the drug has been taken. And leukocytes, there can be leukocytosis or leukopenia. Platelets can be increased or decreased. The typical feature of drug rash, which is important for ICU intensive, is also they'll have pruritus. If you see all the other previous ones, the rash did not have pruritus. Even in dengue, you don't see pruritus. But in drug rash, one thing that possibly we need to ask if you have to rule out drug is whether it causes itching. So pruritus is common. And obviously, you should have ruled out any infective causes. So all infective etiology has to be ruled out. And they can, in a severe drug rash, they can manifest with Steven-Johnson syndrome or erythema multiforme, which is the severest sort of a manifestation of drug rash. So the last one we look into non-infective is cholesterol embolization. This typically happens after any major surgery where vascular sort of a handling would have happened. So the rash is usually peripheral. It is present in the extremities. Sometimes we see it on the trunk also. Hours to days after a major procedure may have happened or some vascular intervention may have happened. And leukocytosis will be present, platelets will be normal. So one of the salient clinical aspect is they can have eosinophilia. And since it's a cholesterol embolization, you can have ischemic sort of a event. So they can manifest with stroke or ACS or limb ischemia. So any of these. And typically cholesterol embolization manifests with some sort of an ischemia in the digits. So this is a pictorial representation as to how it can manifest when there is a multiple cholesterol embolization that may have happened. So this is in brief about the typical ICU cases we see with skin manifestations and their clinical profile. So now we'll slowly move to the published studies on rash and fever in ICU. So I will talk about 4 studies from the Western countries and 4 Indian studies. So we'll just look into how these studies have been done. As I said, they're all sort of a case series, retrospective and prospective, observational, descriptive sort of a studies. So this is an old study which has come from UK, Dunhill et al., 1994. Just go through slowly. They have looked at 27 patients and looked at 27 lesions. And here they're categorized as which are the ones which are life-threatening. So the 5 of them who presented with skin lesions had life-threatening systemic manifestations and systemic other organ involvement or systemic manifestations was present in 10 out of 27. So what we are interested in who come to ICU with systemic manifestations. But if you look at ICU mortality, it was 33%. So some of the studies, obviously, they are not looked into length of stay or hospital mortality. So this is another older study from Spain, Badia et al. They have looked at 46 patients. They've looked at 51 lesions and none of them were life-threatening. So the study is not of relevance to ICU, but 14 of the patients had systemic manifestations. As you see, the length of stay is very long. So the thing to highlight is anyone with sort of a skin manifestations, they have morbidity factor. They tend to stay longer in the hospital and they have some bearing on mortality because they looked at ICU mortality as 26%. So this was a little recent study from UK, George et al., 2008. This is possibly the largest, where they looked at 2,406 patients, examined 2,406 lesions, 199 were life-threatening, 61 had systemic, and if you see ICU mortality is 27.5 and hospital. So what this basically denotes is anyone with skin lesion, possibly for intensivist, we should look at skin also as one organ. And if there is a skin involvement, it may have some bearing on the mortality. And the mortality is anywhere between 16 to 40% if you look into all these studies, because 27.5 in this study. So this was a study which came from Netherlands, more recent, 2011, 42 patients, 46 lesions, 3 systemic, ICU mortality was 16%. So these are all the Western studies, basically trying to tell you that don't ignore skin lesions. They have a bearing with mortality and morbidity, and they have systemic manifestation is something that one needs to look into. So we'll move into Indian studies. So this was by Indian studies, Prashant et al. 2012. 318 patients, they looked at 361 lesions. If you see predominantly 284, more proportion of patients have systemic manifestation. This is a CMC study, which is possibly a good study. But if you look at ICU mortality, it's quite frightening. This is the highest mortality that you can look into all the published studies. If you look at CMC study shows highest mortality correlation with skin lesion, 46.1%. That's why I said 16 to 46% is the range of mortality. 29 patients had systemic manifestations. So this is another study which is more recent, 2018. You can look the mortality. So there is a huge sort of a variability in ICU mortality, but you can remember the figure as 16 to 46% as the range of mortality, and some correlation is there. So this is Gupta et al. Again, where they have looked at length of stays, which is very long, 17. So length of stay, you can keep it as 17 to 19 days if they have skin lesions, which means it has a morbidity factor. So that's what I wish to highlight. I think if you remember that from these published studies, that's good enough. So now we'll slowly move to approach. How do we approach a patient with fever and rash? So it is important you do a good inspection. You have to expose the whole patient and see, which seldom we tend to do in ICU. We have to expose the whole sort of a body surface to see where all the skin lesions are present. And one needs to palpate also. One needs to look at the site of infection and how is this skin rash sort of spreading and whether there is change in morphology. So this you will reflect upon when I take you through the case that we manage in our ICU, because the skin rashes don't remain the same. They do change in morphology over time. So look at the site, look at the spread, look at the change in morphology. And very important, any skin lesion, ask for any prodromal symptoms, whether they've had any history of flu-like symptoms, headache, nausea, vomiting, GI symptoms, so on and so forth. And most importantly, when you are looking at the skin lesions, look into the oral cavity, mucosal surfaces, because if mucosa is involved, it gives you hints into other differential diagnosis, because drug rash involves mucosa. Even in dengue, you'll see a lot of rashes in the palate, gum bleeding, so on and so forth. So look into oral cavity, look for any skin rashes or mucosal involvement as you see here that is present, and look and do a detailed systemic examination. If someone has encephalopathy, it does reflect on severity of the whole systemic disease, and it can point out to more viral problem or severe bacterial infections or typhoid, so on and so forth. And very important to take a very detailed history on any new drugs that they have taken. They may be taking some normal drugs for a very long time, but always good to ask if there is any new introduction of any new drugs, any new antibiotic they have taken. And travel is very important. I'm sure most of the listeners would know that for rickettsia, we always ask whether they have been traveling to any place. And even dengue, we ask for a travel history and ask for family history, whether other family members within have a similar symptom. So these are some of the important sort of a clues that you can elicit from the family. And also, it is important to find out whether they are immunocompromised, whether they've had any arthritis or SLE or any diagnosed condition on the background for which they may be taking azathioprine, steroids, so on and so forth. So always good to ask this. So this is some of the historical sort of the basics that one needs to address when you're dealing with fever with rash. And you have to do inspection and you have to palpate, look at the extent of involvement of the skin. And once you expose the patient and look for the involvement, if the involvement is involving the whole of the body surface, then the suggestion is you have to categorize and assess the severity using the typical burns sort of a scoring. You use the Lund and Browder chart and mark it as to where all are the skin lesions. It's very simple. You can download this figure and just mark on it as to where all the skin rashes are present on admission and how they are spreading, whether it is extending beyond this. So this gives a very important information whether it is receding or whether it is increasing, and to categorize the severity of the skin involvement. So it is very important that we chart it. So this is what has been suggested also. And then we'll move into, so once you have done your clinical examination, all the good history taking, and you have ascertained the extent of skin involvement, you need to obviously send for investigations. So I'm sure all of your experts in sending protein, CBC, complete blood count, kidney function, liver function, coagulation, and cultures are very important. CRP is something one can do to look at the severity of the inflammation, and vasculitis screening if you are suspecting any of the autoimmune condition. Most importantly, if there is a swabbable lesion where you can take a swab where you have a vesicle or there is a denuded sort of a skin rash, so it is desirable that there is a swab from the skin side that is taken, and it is recommended three sides. Swab has to be taken from three sides. But the most definitive sort of a diagnostic clinching will happen with your skin biopsy. And it is important to involve dermatologists early on to help you establish the diagnosis and to take their expert input. So this is a very standard run of the mill. So I don't think you need to. I'm sure many of you would be doing all this intuitively. So then we look into management. So most important in any skin conditions in ICU, your management principles will predominantly revolve around infection control because so much of skin surface is exposed. They are at a very high risk for secondary infections, sepsis, and septic shock. So stringent infection control measures with reverse barrier nursing, with standard infection control practices like mask, goggles, cap, gloves, and so on and so forth has to be adopted because this becomes quintessence in managing skin rash, especially involving large area with ulcerations or hemorrhagic. It's very important. Good sort of infection control measures are adopted. So I won't go into detail as to how we manage fluids. So basically, all your fluid resuscitation is based on your principles of fluid responsiveness, which I'm sure each of you are experts in. And another thing that is suggested is wherever there is skin rash, one has to avoid putting this BP cuff or putting this adhesive plasters or even putting the ECG probes. So try to avoid the areas which have a skin rash to be avoided when you are using any of these sort of probes. And many a times when skin rash is progressing like vesicular or erythema multiforme, where there is a lot of sloughing happen, surgical involvement also may be needed as a multidisciplinary team involvement. If in some situations, surgical intervention may be needed, especially when skin rash is progressed to becoming gangrenous or ischemic and so on and so forth. So surgical involvement also may be needed. So these are the general principles as to how we approach. So that's overview about skin rash and fever in ICU. So we looked into differential diagnosis, we looked into the clinical profile, then we looked into the investigations, the way we approach, and the broad treatment principles. So the second half of the talk is more about the type of cases we saw and which we have published. So I'll talk through the cases, 5 cases. This is the first case, patient-based learning discussion. 36-year-old female who came with high-grade fever for 5 days with conjunctival suffusion, and she had received antibiotics for 2 days outside. After that, she developed skin rashes for 1 day when she came to ICU. So she came very sick in a hypotension and shock, and with shortness of breath, she was intubated and mechanically ventilated. All the standard infective workup came negative. So what she had was a erythema. She had a intense deep erythema, which later on progressed to urticarial plaques. I'll show you the pictures. I just put in a schematic representation. She had erythema to start with, which progressed to ulcerative plaque. Then she started developing bulle. So this is the typical bulle. I'm sure many of you would have seen in ICU people developing bulle like this. And after this, it becomes very risky. Then they start sloughing, and there is epidermal sloughing that happens. So this is the phase where they go into septic shock, multi-organ, secondary infection sets in because lot of your skin surface, epidermal surface is ploughed off. There is an open, exposed sort of a dermal surface that happens, and that's where they are at a high risk of infection. So this is our patient where you can see the extent of skin involvement. So this is like burns. So you have so many areas of urticarial plaque with hyperpigmented erythematic rashes. So there are both urticarial plaques are there with erythematous rash. As you see in our patient, there was a relative sparing of the trunk. Although I had said the drug rash predominantly will be central. If you see, if you recall my slide, I said central and peripheral, but here, and they can be present on palms or soles also. This was predominantly peripheral. So as you see, the whole of body is involved. So these are the situations where you have to use Lund and Browder chart to sort of represent as to how the skin rash is progressing. After this, as I showed, erythema started with erythema, went to urticarial plaque, and then went had bulle. If you see very carefully, there were bulle which has denuded here, which has given way, and there are exposed surface. Then she went on to epidermal sloughing. See this, how bad it is. So it's almost like treating a burn, but this was typically a drug reaction. So what do we call this? So there was extensive epidermal sloughing, and she needed surgical debridement of these surfaces to get her better. And she did get better. She went home. So because what she needed was a good sort of a care for all these with infection control, good antibiotic, and good principles of ICU. So we published this. It is toxic epidermal necrolysis, as you see, we have published in Critical Care and Shock in 2014. So this was toxic epidermolysis necrosis or Steven Johnson syndrome, secondary to the antibiotic she received 2 days back. As you see, it's very, very rare. It's 1 to 2 per 10 lakhs. So it's a very rare condition, not common, but it's a very dreaded and very life-threatening sort of a condition. So it's a medical emergency. It can be fatal. She could have died. She survived. She went home. She came back to us, and all her skin lesions had improved, and she almost was normal. So the common etiology for toxic epidermolysis necrosis are the drugs. Antibiotics are the culprit, and NSAIDs are also culprit, anticonvulsants and chemotherapy drugs. For our intensivists, anticonvulsants and antibiotics is something which we deal with, so we had to be very cautious, take a good history. For her, it was an antibiotic that she received. We still don't know what antibiotic. We asked her to get it. I think I cannot recall. We didn't capture it as to what antibiotic she had got. So the pathophysiology of toxic epidermolysis necrosis is there is extensive keratinocyte apoptosis. So keratinocyte is what is needed for skin integrity. There is a lot of auto destruction of keratinocyte that happens because the keratinocytes express HLA when there is a drug reaction and the cytotoxic T cells get activated. They release a lot of cytokines which destroy the keratinocyte. So there is keratinocyte apoptosis, which is the cause for toxic epidermolysis necrosis. And the typical progression of skin rash or toxic epidermolysis is this erythema, arterial plaque, bullae, and epidermal swelling. And many of these patients can have neutropenia and thrombocytopenia, and it can lead to multi-organ dysfunction, which this patient did go into multi-organ dysfunction, and she nicely recovered. Later on, she had to undergo tracheostomy, so on and so forth to wean. Treatment is all the principles of Burns therapy has to be adopted while treating these patients. And steroids is hugely controversial, although every dermatologist will use steroids. But if you look into core literature, there's really no robust evidence to say steroids help. So in this, we did give a short course of steroids and we did wean her off very soon. But steroids is controversial still. There's no definitive evidence at this point of time. So that's about toxic epidermolysis necrosis. So this was one case. So we'll move into the second case. So this was a 51-year-old female with sarcoidosis. As I said, she has immunocompromised history, as you see, and she was on azathioprine. So she developed rash, erythematous rash on the medial side of the thigh for 3 months. She's been having the rash for 3 months. Then it gets progressed to rag with a necrotic rash. So this is a necrotic rash which gets progressed, extends with a ragged, undermined edges with a violaceous sort of a texture. Violaceous is a violet colored rash. So it's very typical when you look at the diagnosis, you'll know. And we published this report also. And then this rash extended to lower abdominal wall. Okay. So the biopsy was done of this rash because this is a long-lasting rash with the background of sarcoidosis on immunosuppressant. So the biopsy was done, which showed this is a neutrophil. There's a lot of neutrophilic debris that is present. Then there's a lot of fibrin presence within the neutrophils, which is the hallmark for diagnosing this skin problem. So none of us are dermatologists. Obviously, we have involved dermatology in all of these cases. So skin biopsy typically shows this lot of fibrin within and lot of neutrophil debris that is present, which is a hallmark for this. And this happens due to aberrant function of the neutrophils, or it can be genetic predisposition or immune dysregulation, which was the case in her because she had sarcoid. Possibly that was the trigger for her developing this condition. So obviously I would ask audience, what is the guess in this condition? So what we published, so for this patient, we used prednisolone pulse therapy for 3 days, and then she was weaned on oral prednisolone. So obviously, I would ask the audience what is their guess as the cause is. So the condition is pyoderma gangrenosum. Okay, so we published this in one of a good journal. So this is how the skin looked. As you see, it's a necrotic, violaceous sort of an ulcer present on the medial side of the thigh, extended to the abdomen, and it was an immunosuppressed patient. So we published this recently. So, and this is the histopathological slide of this particular patient, which shows a lot of neutrophilic debris, which you see neutrophil with nuclear debris and fibrin, suggestive of pyoderma gangrenosum. So I'm not an expert in histopathology, but that is how the slide looked. So what is pyoderma gangrenosum? It's a very rare condition. Like is 10, I said it's 1 to 2 in 10 lakh. This also is very rare. 3 to 10 patients in 10 lakh patients. It is seen in young females or middle-aged females. It's a neutrophilic dermatosis. 50% of these patients will have systemic disease, and the more common systemic disease are irritable bowel disease or arthritis. She had scleroderma, so arthritis or hematological disorder. So sorry, he had sarcoidosis. So any of these are the common systemic disorders that this pyoderma gangrenosum is associated with. Most important, if you see a rash like this, we had a surgical involvement. We are very clear that she should not be subjected. Like previous case, you saw a lot of surgical debridement was done. But in this, surgical debridement would worsen her condition. That's what we call as pathergy, because the skin lesions will keep spreading wherever you put a blade or a needle. So this is the typical condition where surgeons should be away from this, and they all heal by themselves. And she started healing well with just steroids and supportive management. So pathergy is what is common in pyoderma gangrenosum. So, this patient did recover. Then she went home. She came back with severe sepsis with some other abdominal pathology, and she eventually succumbed. But this was a very interesting case. So we'll move into case three. Again, this we published uncommon skin manifestation in obesity. So this was a 56-year-old gentleman, morbid obesity, 160 kgs. So he came with obtundation with CO2 of 100. So he was intubated, mechanically ventilated, and this was the skin he had. So it's an uncommon skin manifestation in obesity. So he came in very sick with this sort of a skin rash. So this sort of intrigued us. We were perplexed as to what this skin is. So I would ask the audience, what do they think it is, which we published. So obviously we have published, it must be rare. So this is keratosis pilaris. So it's a very rare condition. So basically they'll have insulin resistance, and the type of rash is small peripheral follicular spiny papules predominantly present on the extensor surfaces of the limbs. It is usually present on the legs. The pathophysiology is because of whatever their obesity, insulin resistance, there's a lot of keratin production. So before we saw in toxic epidermolysis, there is an apoptosis of keratinocytes. Here there is excess keratin production, and this keratin blocks all the skin follicles. So, and this is the cause for this sort of a skin manifestation. The treatment is keratolysis, retinoids, and topical steroids, not systemic steroids, topical steroids. This patient was extubated, got better, and went, and he was put on all these dermatological medications. And the diagnosis is keratosis pilaris. So we see a very distinctive sort of a skin manifestation. So it is important to look into out of the box and involve multidisciplinary team, mainly dermatologist, and make a diagnosis of this. So then we'll talk into the fourth one, which is 70-year-old male admitted as a referral from another hospital who came with abdominal symptoms. And I'll just run through it. Progressive worsening of shortness of breath, came to our hospital with saturation of 80% on room air. And this was the X-ray where you see a lot of alveolar infiltrates in the lung. So investigations was done. Troponin was negative, echo was normal. So if you see, he had a multi-organ dysfunction, create borderline, liver enzymes slightly high, urine was normal, cultures were negative. All the infective workup was negative. You saw the X-ray, showed lot of alveolar infiltrates, came as a referral from hospital with GI symptoms. And he went with constipation, then he was enema was given. So all infective workup was negative, cold agglutinins was negative, and this was the CT. So what would you think? You would think it's a pneumonia and you would start treating, prone them, do all those sort of things. Then we examined carefully. This patient had this rash. So you see, this is a vesicular rash. So if you see carefully, he had a lot of vesicles on the body. So this was the patient. He was intubated, mechanically ventilated. So the clincher in him was careful examination, systemic examination, dermatological examination, which showed skin manifestation vesicles. And we did a Zank smear, bedside Zank smear, because he was very sick. So, and it came as varicella. So Zhang smear was positive, and these were the inclusion bodies that were seen, treated as varicella zoster. So the learning point is always desperately look for the source, because you could have easily labeled him as pneumonia and treated him with ceftriaxone as he would not have improved. Here we had to treat him with antivirals. We had to treat him with acyclovir or ganciclovir, so on and so forth. So history is being important. Systemic, detailed clinical examination is important. Appropriate tests to clinch the diagnosis was very important. And never ignore skin lesions. That's what is the main lesson here. Because you could have just said there is some sort of vesicle and ignore. We did the Zhang smear, proved it to be varicella and treated, and he did improve. He went home. So for Zhang smear, the highest titers are seen in 24 to 48 hours. And and after that, it becomes negative because the clearance from secretions happen in 7 to 25%. But the disadvantages of Zhang, the typical inclusion bodies are something like that you see. Disadvantages is you need, because we had a pathologist who came to our ICU and did the smear. So you need that expertise in preparing the slide and interpreting that finding. Because if you do not have that expertise, it's very easy to miss this diagnosis. And GIMS or right stain is what is done. And definitive test is HSV PCR. It came positive for this patient. So that's about the fourth case where again it highlights systemic examination and not ignoring skin lesion is terribly important. Then I'll come to the last case. This is very intuitive. There's no secret in this. You see this, this is a case of lipedema with acute bilateral lower limb. Again, this we published in one of a good vascular journal. This is actually very rare. So if you see this, don't ignore. This is called lipedema, which is very rare. But why it is rare in this lipedema was the risk factor for this patient to develop bilateral arterial thrombosis. This patient developed arterial thrombosis below the bifurcation of aorta, as you see here, and popliteal artery thrombosis. So this was rare. We looked into literature. And in this, you do something called stemmer sign, where you are able to pinch the skin very freely below the second metacarpal, is a typical hallmark sign to make a diagnosis of lipedema. When we digged into the literature, it's called stemmer sign. So lipedema was described in 1940 as fat legs or orthostatic edema. It's also called as adiposis dolorosa or Derkam's disease. And it can mimic. When you see lipedema, we were thinking whether it is lymphedema, whether it is DVT, venous. That's when we did the venous thrombosis. And DVT was negative. What she had was arterial thrombosis and she had to undergo surgery. And the reason for lipedema is the adipocytes. These are the adipocytes. They release lot of adipokines, which leads to a lot of platelet aggregation and activation of platelets. So, which means if someone has a lipedema, they are at a high risk of developing venous or arterial thrombosis because a lot of adipokines are released and platelets become very sticky, and that is the hallmark of this condition. So, the prevalence of lipedema is 10 to 23%, and unfortunately, it is unresponsive to the weight loss because even if they lose weight, the fat around the legs continues to remain. Maybe surgical interventions, I'm not sure, maybe the answer. There are three stages described in literature. Stage one is they have a normal skin. Stage two is they have skin indentation. And stage three is where they have large extrusions leading to deformity. So our patient had stage three lipedema. And she had it for 10 years. It had gradually progressed. Predominantly, it's present only in lower limbs. Actually, she did not look very obese. But when we see her legs, it was very bulky. So she had grade 3 sort of a lipedema. So that's about the 5 cases. So I had one rickettsia also, which we published, but anyway, I thought that was run of the mill case. We published because of rickettsia and secondary HLH and isolated third now palsy is what the patient had. So the take home message is dermatological manifestations are difficult to diagnose in ICU, but it is very prudent and important that every intensivist pays attention to any skin manifestations and try to ascertain the cause for the skin manifestation. Don't ignore any skin manifestation. So daily examination of skin is important, and detailed systemic examination becomes all the more important if you have a skin manifestation. That's what was elucidated in all the studies. And only then you can do diagnosis specific treatment, because if you see skin and keep applying lotions, steroids, it won't help, because in ICU they almost always have a correlation with systemic manifestation, and you need to ascertain the systemic cause, and it has to be a diagnostic specific treatment. And dermatological manifestations, as we saw, has a high morbidity because length of stays in ICU can be increased. We saw that toxic epidermolysis necrosis. She stayed for very long time, I think more than 2 months. So it has a huge morbidity and it has a mortality. And we saw in all the studies, the mortality ranges from 16 to 46%. And the principles predominantly rest with good ICU sort of a care with a good infection control practices and multidisciplinary team involvement, predominantly involving dermatologists and in some cases, surgeons also may have to be involved. So thank you very much. So you can visit my website www.drpradeeprangappa.com to rehear to this lecture. So thank you one and all.